Good morning, everybody, and welcome. Thank you for coming at this early hour. It is my distinct pleasure and honor to introduce this year's Education Day speaker, Dr. Larry Greenberg. Dr. Greenberg comes to us most recently from George Washington University, where they have been fortunate to retain him as a senior consultant for medical education, and he is Professor Emeritus. Dr. Greenberg completed his undergraduate degree at the University of Toledo and his medical degree at The Ohio State University School of Medicine. He completed his internship at Buffalo Children's Hospital and his pediatric residency and chief residency at Columbus Children's Hospital. He then served for a couple of years in the United States Army at Fort Meade before rolling into his various roles in medical education. His involvement in medical education spanned multiple institutions, including Johns Hopkins, Holy Cross Hospital of Maryland, Children's Hospital National, and George Washington University, where he is now. Within these institutions, he climbed the professorial ranks, and he served in various medical education leadership roles, directing multiple programs and starting multiple programs. Dr. Greenberg has close to 150 publications, nearly 100 abstracts, and written numerous book chapters covering both clinical and medical education topics. And he's been presented with multiple teaching awards. Incredibly, Dr. Greenberg has also made close to 350 presentations throughout the country. That's covering, including probably 2/3 of the medical schools throughout the country. I believe you will find Dr. Greenberg equally as impressive as his CV as he engages with you to discuss a closing discussion on the 8-step preceptor this morning. Please welcome Dr. Larry Greenberg.
So a couple things. Thank you so much for a lovely introduction. Sherry and I go back, I don't know, maybe 10 years or so. But one, she sets the bar high. Now I'm feeling the pressure. Two, you started clapping, you haven't even heard me. So, you know, this is, I hope I live up to your expectations. It's good to be in Hokie country. I never thought I would say that. I just dropped off a grandchild who was on a 3-day break in Blacksburg, saw the campus there. He's an engineering student. I said to him, I said, Bradley, I said, you know, wear the t-shirt when I'm on campus and everything, but I'm a Buckeye, and it's hard for me to switch allegiances. I said that to my other grandchild at Indiana U and my third grandchild at the University of Virginia, so, you know, I'm wearing all kinds of t-shirts, but I got to be a little careful about my allegiance to my own medical school and my training. So I've got some great news for you this morning. Oh, the bad news is it's 7 a.m. for some of you. To me, this was a usual. I started work at 7 for lots of reasons, but the good news is I have no slides. So you're going to stay glued because you're going to find out how this session is going to work in a second. But let me just do a brief introduction. To me, this is one of the most important things we do as clinicians, that is case-based teaching. And that's what the session is going to be about. And we've done a little bit of study around case-based teaching to see how we make it more efficient and effective, developing a model, and we're going to talk about that model today. The way the session is going to unfold is that we have a medical student whose arm was twisted, Cammie, who happens to be going into pediatrics, my own specialty, pediatric emergency medicine. So she and I are going to do an unrehearsed session as if she just saw a patient in the ambulatory department. And your job, so you don't go to sleep, is you're going to focus on how effective I teach, looking at things I do to promote learning and looking at things that I do to inhibit learning. So what's going to happen after that 5-minute session with her is you're going to do some evaluation, as we'll see, in terms of what you saw you liked and what you saw maybe you didn't like. And that's the way the hour will go. But to start out with, I want to talk about, because I would assume that most of you in the room do case-based teaching, maybe some of you don't, but whatever. What are some of the barriers that we face in case-based teaching? And you're going to have to talk loudly because not only can I not hear so well, I'm deaf. I'm quoting my grandmother. She once said that. I never thought I'd say that. So what are some of the barriers?
Time.
Yeah, we could stop there on that. We could write time with a big capital T, because that's the major issue. This is a patient-driven, environment. We got RVUs. People are looking for us to turn over patients and keep the academic health center going. But in the meantime, we have a major responsibility of turning out future physicians. Not just future physicians, but excellent future physicians that know how to communicate and do things really well. So time is certainly a big one. Let's hear some others. Please.
You may not know where the learner is at.
Beautiful. So Dave Irby, who's a giant in medical education from Seattle, would talk about diagnosing the learner. How do we diagnose the learner? How do we know where the learner's at? If we don't know where the learner's at, how do we know what to teach? That's an important one. Sometimes we make assumptions about what the learner needs to know, but we haven't even gone there to find out, what the issue is. So that's a beautiful one. What else?
Different levels of learners.
Different levels of learners. So then the question becomes, and for me, this is a hard one. I don't have any answers for this one, but in terms of the curriculum for each level, how many of us know the curriculum? I guess you could pull it up easily on an iPhone or something today, and I think that's probably what the students do, maybe not, in terms of, for this particular patient, what are the competencies we're dealing with? What are the milestones? Or in the old days we would talk about objectives. What are the objectives for this particular interaction? So we kind of go in without necessarily thinking about that consciously. And when I ask the students or residents, the same questions, they look at me like a deer in headlights. They don't know what I'm talking about. Competencies? Not sure what those exactly are. Students, the same thing. I think that's changing, especially as we are in a competency-based environment, both at the student level and resident level. But we need to think about, levels of learners, what's appropriate at each level, what should I be teaching, because that's important. Certainly you don't want to fall back on my research. That's not appropriate. Sometimes that happens in terms of talking about things that are outside the boundaries of what the students and residents need to learn. So really understanding where we should be going with this particular patient is important. What else?
Prioritizing teaching points on the fly.
Okay, prioritizing teaching points. So, in this brief period of time that we have, we want to make sure that the trainee is getting what we think would be appropriate for them to get. And so, I don't know how you do that, but, kind of highlighting your teaching points or having a resident or a student summarize what they think the teaching points were for that particular session. Just to make sure, because, when I'm teaching and I'm talking, I'm never sure what the learner's learning. That's a quote from Jerry Harvey, who wrote a very funny, beautiful 3-page paper called Learning to Not Teach. Learning to Not Teach. He was from the Organizational Behavior School at GW, one of the funniest guys I've ever met. This 3-page article is a hoot. And basically what he said is classroom teacher, when he went into the classroom and he was talking, he never sure learning was occurring. I challenge anybody to tell me that you know that. Some people say, well, the students are attentive. That's fine. What kind of learning is going on? But he said when he was quiet and there was cacophony from the students, he knew learning was occurring because the students were talking and he could hear it. He knew learning was going on. So that's important. I'll just throw out another one, learning styles. People come to us with different learning styles. That's part of adult learning principles, where, some people are, verbal, some people need to do hands-on, some people need to listen. It doesn't mean that we have to change the way we teach every single time based on the student, but sometimes we have to ask our learners, what's the way you learn best? So somebody brought up an issue one time about He was teaching something, I don't know if he was a neuroscience or scientist or whatever. He said to the resident, talk to me about the circle of Willis and its implications in terms of, how patients would present with problems. And the trainee said, I can't talk about it, but I can draw it for you. There you go, learning styles. So people do come to us with different learning styles. And I will tell you that my worst evaluations, which not surprisingly, because I'm a facilitative learner, my evaluations that are worst are from students, small minority, and residents, small minority, who say, just tell me what I need to know. And I'm thinking, oh God, I don't know what you need to know. Just trying to make the learning go forward. And that's my major issue. I can't tell you what you need to know. I would have to spend a long time with you to know that. So those are some of the barriers. Any others that, people, time is the big one. Time is the big one. So Cammie and I are going to interact. The session will probably be close to 5 minutes. You will excuse her. I just met her 20 minutes ago. I told her she is not on the spot. I am. She will read the case. Excuse her, because I wouldn't normally let a student or resident do that. But she just got the case a few minutes ago. Again, the simulation will be is that she will just have seen someone in the clinical setting, and I will be engaging her as the preceptor down there, and we'll spend a little bit of time trying to figure out what to teach her, and then the evaluation will ensue from there, and then we'll segue into the model. We okay? Okay. Oh, someone changed their chairs. Well, we'll just do it again. Notice the way I arrange the chairs? Not this way. It's a little confrontational. This way. Cammie, you have a patient?
I do have a...
Great, let's hear it.
Okay. I just saw 5...
Are we good in terms of sound?
Okay.
Okay, should she take the mic?
Yes.
Okay.
I just saw a 5-year-old white male that presented with a history of spots all over his body. The child was perfectly well until about 10 days before the visit when he developed a cold. So with runny nose, cough, sneezing, no fever, was relatively well until 2 days prior to the visit when his mom noticed a reddish, purplish spots on his trunk and extremities. They're non-tender, the largest one is about the size of a quarter. He goes to preschool and has some sick contacts, but no one has similar findings. Mom states she's given him Robitussin cough syrup during the illness and his cold is better. He has been active with a slightly decreased appetite, no bleeding points like in his bowel or urine, no one in his family is ill, and the child's review of symptoms is totally negative. Mom is concerned because she has a nephew with blood cancer who presented with similar spots. Birth history uneventful, is full term, circumcised, no bleeding, development has been normal. Family history, one younger sibling in good health as are the parents. Mom is 32, works as a bookkeeper for a small company. Father is 30 and works for a pest eradication company. Physical exam, normal appearing child, no distress, vital signs are within normal limits. Findings are related to the skin as he has pinpoint and quarter-sized lesions. Most of his abdomen, extremities that do not blanch on pressure.
What does that mean?
Per breath.
Oh, good, okay.
He has a few shoddy cervical lymph nodes that are non-tender, and his liver and spleen are not palpable, but I actually didn't percuss these organs. The rest of the exam is normal, and like differential includes vasculitis, like HSP, ITP, some sort of bleeding disorder. That's it for right now.
Wow. So that's a good differential. So what level are you?
Fourth year.
You're fourth year. Wow. I'd like to have you in my program. That was a great differential. And a great presentation, by the way. A very succinct presentation. So you mentioned a number of different diagnoses. How did you come up with those?
Based on the history of physical so far. So, for example, he's been having like the spots that mom described, and also on physical exam are most consistent with purpura. So I was trying to come up with a differential for purpura.
Okay, so you listed a couple of things. You said vasculitis, which is an interesting suggestion based on purpura petechiae. And you also mentioned ITP, which also is a valid part of the differential. What else did I miss?
I just said some sort of bleeding disorder.
Oh, okay, okay. What if I hypothetically told you that the spleen, I percussed down to the, I couldn't feel it, but I percussed down to the iliac crest. So this patient had a very large spleen. Now, you didn't feel a spleen, correct?
No.
That's not unusual. If the spleen is large, you may not feel it, unless you start all the way down and come up. But that's why percussion might be important here. You know, if you hear dullness instead of, if there was no spleen, what would you hear when you percussed in that area? What's normal? Timpani, good, good, okay. So what if I told you the spleen was large? What would that do to your differential?
Make me think something more like ITP. Something that's causing splenomegaly, so why is the spleen enlarged? I don't really remember all my blood disorders off the top of my head right now.
Well, that's okay. So the question would be, and that might be something you'd look up, is what would give you purpura petechiae with an enlarged spleen? And I would just tell you that would rule out ITP, because we don't see with ITP a big spleen. It would make us think of something else. Like maybe blood dyscrasia, like lymphocytic leukemia or something like that. Good. So let's go in. I want to talk to the mom a little bit. You might want to watch what I do, because obviously she's worried about some blood dyscrasia because she has a nephew with such. I'll go in and make sure the spleen is not enlarged, and then we'll come out and talk. But as of right now, if I asked it, I'm not saying you should, but if I asked if you wanted to do any lab work, what would you do?
CBC, start with that.
Looking for?
And a blood smear.
Looking for?
The white count, also see if abnormal blood cells in his peripheral smear.
And you missed the third one, so we have...
Oh, platelets.
Platelets.
Yeah.
Great, okay, let's go in and see the patient, and then we'll go from there. Ta-da! Why did you give me such a great student? I mean, you know, could be an attendant. Okay, so I don't know how long the session lasted, probably 5 minutes. Let me ask, can everybody see back there? Should we stand? Would it be better if we stood? We okay? Okay. So, Cammie, just your overall Gestalt feeling, how would you regard this as an interaction in terms of teaching on a 1 to 5? And of course you're going to tell me why.
I would say a 5 because, well, I felt supported in my learning, even though I didn't know some of the answers to your question. I didn't feel like you were condescending to me. You helped me. You helped me figure out what I already knew and use that to teach me something new. For example, that splenomegaly would rule out ITP. I didn't remember that initially. So.
Any downsides in terms of what happened?
No, not that I can think of. I usually prefer an interaction like this with an attending when I'm trying to learn, not someone that just wants to point out what I don't know.
Okay, let's hear from the audience. I can take it, don't worry.
One of the things that sort of concerned me a little bit as it was opening up, as the presentation was opening up, is that relatively early on, you made a number of points predicated on part of the physical that you, in fact, weren't, at least in impression I got, you weren't entirely sure that she had done this whole thing about the spleen. I mean, clearly the differential makes a big difference as to whether or not the spleen is big or small. And you seem to be making teaching points based on something which may not have been true when you actually went in and re-examined the patient, in another 2 minutes.
Okay, so
So you were sort of putting the teaching before something that was actually relevant to this case.
before it all unfolded. Okay, so I think, and I, again, when I do this, it's never the same. It's never, I don't know what I'm doing. When I'm engaging a student, it all depends on the student. So I think you might be referring to my hypothetical, where I put a hypothetical in and said, what if I told you the spleen was large? Because sometimes, I see where a student or resident will miss a large spleen because they feel right over it, but they don't feel all the way down up, and they don't percuss it. I hear your point, so that's a valid criticism.
I just looked at that differently in the sense that I felt that was your way of emphasizing the importance of learning how to be physical, that you felt for it, you didn't feel the scream, but if you had percussed, maybe you could see that it's enlarged and it would change your differential. So I think the way, I guess I didn't feel like the hypothetical was really the teaching point more than I felt like the importance of good physical examples like the teaching point.
Okay, that's valid also, and I think to differentiate between the 2 points here, both of which are interesting points, is not sometimes, all the time, we have this going on in our head because physicians think in scripts. Seasoned physicians think in script. So when you say, well, this is a 40-year-old woman who has abdominal pain in the right upper quadrant an hour after eating, and she's obese, everybody's smiling. We know what the diagnosis is. That's a script. And that happens to all of us, no matter where we're practicing. There are a lot of times where there are no scripts because we don't know exactly what the patient has, but we oftentimes think in scripts, and in our enthusiasm, and in the short period of time we have to teach, we sometimes want to just give it up to the student or the resident in terms of like how I'm thinking versus how is she thinking through it. She's a novice, relatively. Well, I can't assume that. We're going to ask her about her previous life experiences, which most students and residents never hear from faculty. What did you do before you came to medical school? I once had a PA student. He's in the clinic, first day, we're chatting before he sees a patient. I said, what did you do before you came to medical school? And he said, I was a PA student for 12 years. I said, whoa. I said, the bar just went up for you. And he kind of paled, and I said, no, that's good. I said, knowing that you've had that kind of experience is important for me, because it doesn't mean you've seen the world, but it means you've seen a lot, and I need to treat you a little differently than some of your peers who haven't had that experience. That's what I'm talking about. So, yeah, okay.
I think one of the jobs of the generalist is to pick that needle out of the haystack. And I found with her, you were very even with your feedback with her. How do you balance emphasizing, the thing you do not want to miss is you want to make sure this is not repeated, right? Because that's part of your differential. And balance, she said she felt supported, but that's also something that's crucial that she has to know from this interaction that you cannot miss that.
Okay, so there's a really, really interesting point. So I'm going to refer this back to Cammie and try and tie this in with your comment, because I think it's important. What was my teaching point?
Going over different, well, we did spend a lot of time talking about the spleen and how, well, that's where we started. I feel like that wasn't a full teaching session. I think we would have talked more about that case before we opened it up, if this was an encounter in other places.
What do you think?
You see a part of it. I'm not sure if it's...
Okay, I think your point's a very valid point. And when I asked her that question, did you see her body language? Her brow wrinkled, she went, It's clear to me, based on this unrehearsed interaction, that she wasn't totally sure what and I'm addressing what you just said, in terms of, I got this 5 minutes, what do I want to get across in this 5 minutes, in terms of, what do I want the resident or student to take away? And, have that sink in, that this becomes very contextual as part of adult learning. You see a patient, you get teaching on it, and of course it doesn't end here, she's going to go read about it, right? She's going to go read about it, and that's all going to come together, versus going to read the New England Journal, the latest issue, and picking out an interesting article, but no patient connected. That lasts about 2 weeks, that knowledge. After about 2 weeks, you hold on to about 20%. Good studies on that. Why? No context. Our neurons just don't, I hope there's not a neurologist room, but our neurons just don't, they don't go that way. They put things together. And that's the way we think. So she needs to read on this and develop some context, and then it all fits together. Yeah, there was another question back here. So how would you grade me on this? Huh?
I grade you 5.
5 also?
Yeah.
Where's Sherry? Are you hearing this? This is strong stuff so far. It's a long drive, but I could come back anytime. Who else? Who's got something? Come on, somebody's got something. Yeah, go ahead.
3.
3?
It's not over yet.
What do you mean?
You've got to go see the patient.
Okay,
You've got
true.
to form your own opinion. You've
That's
got
true.
to revisit what she missed. You've got to do your own exam. You've got to put it in your context. And then that shapes then what you want to teach, because I'm still, does this person really understand what purpur is? And then you've got this whole preceding illness that preceded the rash, and that makes me think of other things.
Beautiful. So it's
You're not
unfolding.
done yet. You're not done.
You're not done yet. You're going to go in the room and you may end up teaching in the presence of the patient, depending on the situation. I mean, I wouldn't be discussing leukemia and stuff in front of this mom. I might have gone in and talked to the mom about her concerns about her nephew, and talked to her about, once I repeated the exam, what I thought was most likely going on. And this patient was going to be ITP. Was no spleen enlargement, and all we had to do was, get a CBC and show the thrombocytopenia, versus HSP, which, what are the platelet counts in HSP? It wasn't the right distribution anyway. What's the platelet count in HSP, do you know? Huh?
Decreased.
Normal.
Normal.
Yeah, non-thrombocytopenia and purpur. It's the only one that's not, it's because it's a vasculitis. Yeah, so going in the room, confirming what she told me. Not a lot of time coming out of the room, but I could have reinforced some of the things in a differential and done that outside the room, and that would have kind of pulled things together. But your point's well taken. Your point's well taken. The bottom line is we do not have a lot of time. And whereas this may have been 5 minutes, and in the room could have been another 3 or 4 minutes, and coming out could have been another couple minutes, so there you got it. And that's about as much time as you're going to have. Because someone's going to be saying, your next patient's here. Okay, so 3. What else? Anybody else?
To Don's point, I was thinking that that's something hardcore that you could just put them in there. Sure, they're going to go read more about it. But the one thing that you need to make sure that this isn't that could be, that's on your differential is leukemia. How do you know that this isn't? How are you going to rule that out, right? That's one of the most important things. So would you include that in your teaching points with her?
Yeah, so, in this initial, interaction, I asked her if she were going to do any labs, and I wasn't telling her to do a lab. What would you do? I loved her approach. I do a CBC. It's not expensive, it's not invasive. It would give you a lot of information about 3 cell lines. Okay? Hemoglobin's okay, white count's okay, platelets are down. No spleen, the most likely diagnosis. It doesn't mean it rules out ALL, but it likely does. It likely does without any hepatosplendomegaly at this point, or lymphadenopathy or other things that may have gone along with it. So Yeah, I mean, that's a patient that would deserve watching, but she went down that route. She not only had her differential in mind, she also had in mind what she might do to kind of separate some of these things out, even though she didn't know exactly HSP and HSP and non-threatened thrombocytopenia. I wouldn't hold that against her. But for her student, she's not a resident. Please.
I was struck, and it's probably coming from the perspective of the community physician, is that we as physicians can get caught up in the teaching about the facts of medicine. And what I appreciated most about the interaction is she tied up a lot of teaching skills with her in such a way that not only is the detail important on physical, you have to tie the whole things together, but you also brought in the perspective that and going over each of the different children, and we're teaching along the way, and then you brought in a mother, and let's put them together and do this. And I think there is a subtle teaching point that the learner picks up on that. It's not only the rooms of how you are with them, it's how you will be with the feeling, but also that kind of teaching allows a safe place that she offered, and it's going to allow more teaching to go on as time goes on. Whereas we as physicians, we all focus on, did you miss this, physical, and yeah, that's important, but you can tell by the questions that are being asked, that's our focus, is did you teach right, but factually, not the interaction.
Thank you for that point. So, you're describing a process that came out in the Icicle Creek Conference on Teaching in the Ambulatory Setting. I think it was like Irby ran that thing. It was like 1998 or something in academic medicine. And one of the processes that they talked about was activated demonstration. So when you go into the room to address a patient, to examine a patient, and have somebody tagging along with you, you set that up before you go in the room. Watch how I address the mom. Watch what specific questions I ask. Watch our interaction, her body language. So when that person goes into the room, they are activated. They're not standing there like a bump on the wall. They don't know what we know. We are unconsciously competent. They are unconsciously incompetent, starting out as novices. And then they get to the point where they become unconsciously competent. We don't think about every step we go through. We do it it's automatism. We go through it because we do it every day. And to not break that down for a trainee is a big mistake. Because if I just said to Candy, come in the room, watch me talk to the mom, I'm not setting that up. It's not a setup for her in terms of what she needs to watch and what I'm going to be doing and so forth. So your point's well taken. When you take somebody in the room, think about activated demonstration, so you get that trainee focused on what you're doing, and they come out of the room and it's a great technique. I had a student, I'll just tell you, not long ago, where he was a medical student who had never seen a newborn, or never done a newborn exam. I said, you have a choice. You can go do the exam and I'll check you out, or you can watch me do it. But if you watch me do it, I want you to write down everything I do in what order. Do you think he was activated? We came out of the room and I said, so is this usually the way you do an exam on a patient? He said, not the way I was taught. I said, well, why do I do it in that order? Well, it was no heart, I felt the continental, I felt the pulses. It was not any specific order I use. It's just before the baby starts crying, I'm doing things I need to get the information. And that's what came out. That's the teaching point that came out of that session, with him writing everything down. He'll never forget that in terms of what the difference, even if he doesn't know what it means, he'll remember that interaction. Please.
So you just gave us an example with Cammy of case-based teaching. So 2 questions. At what point did you decide what the teaching point was in this unscripted interaction? And number 2, how in the process did you decide what that teaching point was?
Ooh, God, you put me on the spot. I have to tell you something. When I do these sessions, I don't try to model the ideal. I try to model what I think would be reason for you to critique me and give me lower scores. There is this halo effect. Who knows what the halo effect is? Please, describe it.
It's kind of assuming because somebody is in a particular position or presents themselves in a certain way that they have more knowledge or competence than they have.
That may be part of it, but I think the main part of it is just being really nice and really supportive and interactive, and that clouds what the heck went on. So when you start to dissect what the teaching point is, and I asked Tammy, and she furrowed her brow and went, and couldn't come out with it for 10 seconds. She said, well, I think, point being is a halo effect really takes hold here. When you have an attending or a senior resident that's teaching that really is caring, nice, and so forth, but doesn't say very much. And so that's how this session went. So in terms of your question, I never even thought about it, which actually isn't very good. Because once you diagnose the learner,
It's unconscious competence, so I'm
It is.
interested in how people get
Yeah.
from unconscious incompetence to conscious competence and eventually to unconscious.
good. Okay, we're going to slip right into the model we developed. And you've got a hand out there, so you don't have to take notes or anything. It's very well described. You can take up one. So back in the 90s, the family practice group at Seattle developed the 1-minute Preceptor. 5-step process. I looked at it. I said, I don't know. I don't know if this is complete or not. That process really didn't incorporate very much in the way of adult learning principles. So I decided I was going to modify the model, and that's what we're going to talk about today. And the question is when you teach in an evidence-based way around a case, are you incorporating adult learning principles? We're tried and true. Adult learning principles are tried and true. So this is how this is going to unfold. So it's not necessarily lockstep, but it does start off with some things. So one of the first questions, and I will ask Amy this, one of the first questions I ask a student or resident when I engage them is, have you ever seen a patient like this before? Now, I don't know, he may have dropped out, the gentleman over there, but he was addressing this particular issue of diagnosing the learner. Okay, so I'm hearing this presentation and I've got stuff going through my mind, as we all do, because of the script issue, and because the PGY 47 or whatever it is. And I'm going down this path. But the point being is, I don't know where she is, so I will ask you, because that's the way the session should have started. Have you ever seen a patient like this before? No. Whoa. No. And she was fabulous. So if the trainee says no, what is the only thing you can't teach? It's a hard question. You only have 5 minutes. What is the only thing you cannot teach around this patient? The answer is everything. No way could you possibly discuss everything about this patient. No way. Or any patient in your short period of time. That's why the reading and everything is so important afterwards. And they come back to you and confirm how this thing unfolded and add all the pieces to the puzzle and say, this is how I, put this all together. That's what learning's all about. So I can go anywhere with her. Now, theoretically, I should know her level, and I should have some concept of what a fourth-year medical student should know. Certainly, a fourth-year medical student should know how to differentiate per CPI in a patient who comes in sick, which this patient was not, right? You described a fairly well-looking person, a young boy, not that sick, versus somebody that comes in with, DIC or something like that from some horrible infection, whatever. So I can go anywhere with this, but I have 5 minutes, so I'm going to have to choose as we heard over here, what was my teaching point? I'm going to have to choose what I really want to teach in the session, and it could be anything. It could be, don't forget to percuss the spleen in a patient that presents like this, because you could miss a big spleen by palpation, and that would totally change your diagnosis. I mean, that could have been my teaching point, but that's not what I was saying. I was just babbling. Okay? So first of all, find out where she is. Now, if Cammie would have said, oh, I've seen lots of patients like this, then what do you teach?
What does she know about this?
Okay, so you can explore that a little bit. So from the previous patients you've seen like this, could have been in internal medicine, TTP, which is not the same as, we're dealing with here. You could explore that a little bit without taking a lot of time and say, well, talk to me about, previous diagnoses you've seen with patients. That'd be one thing. What else?
So you can ask, so what are you thinking and what would you like to do next? If she's already seen many patients like this, so what are you thinking and what would you like to do next? So you can go farther if she already knows.
So, okay, so taking her to the next step, I'm going to expand it a little bit and say, I could say to her, so how can I help you with this patient? What would be helpful? Now, when you ask a resident or trainee or student that, what response do you usually give them? Okay, blanks there, because no one's ever asked that question before. But, this is a collaboration. This isn't top-down, hierarchical. This is an interaction. That's what teaching and learning is all about. It's not just my telling somebody something. It's engaging them. So asking them, where can I go with this patient? You might get some answers, you might not. Be ready if you don't. In this case, I might have said, hey, if you've seen 5 cases of ITP as a senior resident, I know that you don't get as much on communication skills that you need. I'm going to go in and I'm going to demonstrate, after demonstration, how to engage this mother around her main concern. Because if that's not dealt with, she will leave as anxious as when she came in. If you don't go into that room and say this child does not have ALL, she will be as anxious as when she came in, which is not good, even if you're correct. Okay? So that may be where you're going. You just have to figure out, where you're going. Should we go through some physical diagnosis skills, whatever they might be on a particular patient, and let me demonstrate that for you, or whatever it might be. Be ready to come back with some kind of thing. Again, not lockstep. Listen. So, the case is unfolding, and you're thinking, I know what this is. This is a classic case of, cholecystitis, and your enthusiasm as a teacher, and I think it came out here in the questioning comments, is, let her go down whatever path she's going. It doesn't matter if it's the wrong path. You're here to correct her. And once you do that, she's going to be fine. She's going to be fine. So listen to the whole thing. I did interrupt her once because she said the TCAN purpose. But if you ask the students to help me on this, how often do you get interrupted on case presentations?
Just depends on the attending, the environment.
So I'll give you a percent. How often do you think on every case you see?
40%.
So, the students and residents will tell you it's pretty high. Again, it's not because faculty are rude or whatever, it's just that they're so, they want to move the case along, and they also want to be giving and trying to steer that trainee down the right path. But it's good just to listen, let it unfold. Now, I will say, especially at the beginning of the year for a resident student, sometimes, they babble on and on and on. And the teaching point may be, okay, we got to talk about how to do an effective and efficient presentation. And then I would take over the case in terms of going and doing the physical real quickly, making sure everything was okay. But that might be your teaching point because the case wasn't presented. Okay? So the teaching point can vary, I mean, depending on how this all unfolds, but important to listen. And again, I mean, I'm assuming the students are given some, and the residents are given some guidelines on how we like to hear presentations. I hope that happens. I know it varies from attending to attending. We drive them nuts. One attending says one thing, one attending says another thing. We drive them nuts, but in general, we should have some consensus on how we like the cases presented. Okay, then you get a commitment. Now, I didn't have to ask her. She finishes presenting the H&P and she says, oh, and my differential diagnosis is. I didn't even have to ask her. A lot of times, I don't know how many times, it doesn't matter, but certainly a lot of times you're going to say, so what are you thinking? Okay, so they come out with a couple of things that they're thinking about. You may want to ask them to prioritize them. They may not be able to do that right away until the case unfolds and you go back in the room. But the next step in this is probing. That's very important. Once you hear the commitment, it's probing. How did I do there? Yeah, I said to her, I said, whoa, those are big differentials. Well, how did you go about that? And I didn't probe her enough, but she said, you know, this is petechiae purpura, and I know certain things cause petechiae purpura, and she listed a couple things. And I said, yeah, that's right on target. So probing is important. It's not just a question of, yeah, the diagnosis may sound right, and maybe what you're thinking, but you want to know how the training got there. Please.
Yeah, in this world of being nice, I felt at that point you were being too nice. Oh, that's a great differential. Well, it was a pretty narrow differential. She could have really expanded that.
Yeah, I agree.
And I thought,
I agree.
we're just being too nice here.
So we can give you number one. Speak up. Well, you're right. You're right. Now, that was a halo, 3. I mean, that was a halo. That was a halo. So, yeah. So that could have been expanded. By the way, I meant to ask, what did you think of my feedback? After she finished the presentation, what did I say?
That she was amazing.
I said, what year are you?
Forgot to progress this week.
Yeah, you
Well, before that. I said, what year are you? That was really a good, efficient, and effective presentation. What's the take-home point there? That's not feedback. Come on. I was specific. I didn't say anything specific. That's not feedback. And again, you know, this is faux feedback. It's a nice compliment. It's fine. You can compliment somebody, but that's not feedback. So if I had said to her, hey, you know, for a 4th-year student, that was really a great presentation. What I liked about it is you presented the critical information that I think I needed to know. There wasn't anything that I could think of that I would fill in. You even said the father's occupation, where he worked for a pest control company, and that could that figure into the differential diagnosis? He's bringing pesticides home in his clothes, and, you know, his family is breathing in that stuff. I mean, that's far out, but I mean, yeah, I would have complimented her. That's what I mean by feedback. That's not good feedback. So, yeah, I could have expanded that. And again, I do this session every time de novo. I don't know what I'm going to say or how I'm going to do it. All I know is I don't do it like I usually do. And I'm waiting for you all to tell me I did a great job, which I don't feel I did, because I didn't incorporate adult learning principles. I'm starting out with, have you ever seen a patient like this before? It's an adult learning principle. Where does it fit into Noel's adult learning principles? Noel says that your previous life experiences count for something. It's not assumptions. I don't assume she knows nothing. She was unbelievable in this interaction. I don't assume she knows. She hasn't even seen a patient like this. And yet, look at the interaction. So no assumptions here. I mean, this is where I'm saying adult learning principle. Okay, so you get a commitment. What's that all about? Well, I mean, we do that almost every time. Hopefully we do it with the trainee saying it before we say it. Like, I've seen parents say, oh my God, this is a classic case of closest study. Before the resident ever has a chance, or the student ever has a chance to open their mouth. And that's because of their excitement and so forth, but that shouldn't happen. I never tell anybody what I think before they tell me what they think. They go first. Now, I know what I know. I need to know what they know. So then the probing piece, and then the teaching point. Teaching point. So in a 5-minute interaction or so, you might say, yelling from the rooftop. My teaching point today on this particular patient is, I'll just take this. When a patient presents with purpura and petechiae, looking fairly well, make sure that patient doesn't have hepatosplenomegaly. And if you're not sure about it, make sure you percuss. She knew tympany from dullness. I questioned her on that. I want to make sure she knew what it would be like if there wasn't a spleen there and she percussed when she went in the room with me. Okay, so that's the teaching point. Then the feedback. So there's two kinds of feedback. What are they?
Positive and negative.
No. No. I stole this. I think I stole this, or maybe she stole it from me. I don't know. The woman named Mary Ann Houston, who's a PhD educator, and I think she's still at Cleveland Clinic. I don't know if she took it from me or I took it from her. It doesn't matter. The two kinds of feedback we give are corrective and constructive. It's not negative positive. You know, if you want to tell me about my dress today, you don't talk to me negatively. You tell me, you know, you could have worn a different color blazer. It might have, you know, been a better match with your shirt or whatever. That's constructive feedback. Remember, I said constructive and the reaffirming. I'm blocking on the reaffirming feedback. I'm blocking on the exact name. It's not reaffirming, but it's not. It's that you're doing a good job, okay, and it's not. It's not framed as good or bad, okay? You're doing it objectively in terms of this is what you're doing well, reaffirming. This is what you need to improve. That's the kind of feedback we give. Okay, that's the next two steps. That has to happen in every interaction. If you ask the students and residents how often they get feedback,
I actually get feedback really pretty consistently.
cool. I'm glad to hear that. And that is a change in what's happened. And if that's particular to you all, kudos to you. This feedback is very critical. Okay? Then this, and those are adult learning principles. Knowles talks about feedback as adult learning principles. That's the only way we can grow, is to hear what we're doing well and what we need to improve on. Sometimes we only hear what we need to improve on. If we don't hear what we're doing well, that's a problem. Because we want people to do things they do well to continue. And the last piece is learning objectives. So if I said to Cammie, based on this interaction, what would your learning objectives be for this particular patient? What would you say?
Review my blood disorders,
Just review my blood disorders, so like blood dyscrasia, review leukemia, how that presents, go over how to come up with a better differential for purpura, for example.
So, you know, the trainees are pretty good at accessing information, but if you've got something good for them to read, I mean, outside the textbook, I mean, the textbook for me is still the way to go to get an overview. If there's something that needs to be value added, a review article, whatever, then instead of them trudging through the literature, tell them. Say, I got a great review article for you to read on this. I think it'll really help you think about, you know, this patient in the context of petechiae and purpura. Let's talk about it tomorrow. So she's going to come back, and it could be in front of her peers, it could be just she and I. She's going to tell me what she read and how it integrates with this patient. So that's the model. That's the model. Again, that's another adult learning principle. It's continuing professional development. It's activating the student, the learner. It makes them, it says, this is not the end of the learning this around this patient. You have to go home and read about it. And I demand that. I'm not full-time anymore, but I demand that students and residents read on every patient, because that's how it sticks. That's the contextual part. That's how our neurons work. And people say, I don't have time, and I said, baloney, you don't have time. What you're telling me is you don't have a lot of time. So read in a way that makes some sense. Read 15 minutes. Don't read an hour. You may not have an hour to read. I demand that. You're going to be on my service, you're going to read about your patients. It's the only way to make it work. You're not going to read about it next year. You're going to read about it now while it's fresh and it's happening. And so we can make sure we're giving patients the best kind of care we can give. That's the model. Again, the way this differs from the 1-minute preceptor is building in adult learning principles, which they did not do. So always, if you do nothing else, always start out with, have you ever seen a patient like this before? And making no assumptions, you wait till the learner tells you, and then you decide where to go. If it's, I've never seen a patient, you know you can go anywhere, but not everywhere. If you've seen lots of patients, then you work in collaboration with that learner in terms of what they want to learn about this particular patient. Make sense? Look at that, 5 of 8. So questions? I would just encourage you to practice the model. The model makes sense, and it doesn't take longer than what you're doing now. In fact, it incorporates things that need to be there that we talked about that are, part of adult learning.
I just have a quick question
Sure.
about the handout. It looks like the back sides of some of the pages.
Yes, it looks like all the odd ones are missing.
I'm very interested in learning more about your model, but it just
They're
like the
missing?
odd numbers.
Just the even ones are there.
So some of the pages are missing?
It looks like the odd steps are missing.
Yes, so that is our fault, and we will have the full handout posted on our website, but to the people who attended here and signed in, we will send you this
Oh, thank you
specific
so
one
much.
directly. I apologize, it's our fault.
Oh, see, it could have been me, and I was ready to do a mea culpa, even though I'm sure.
No, I don't think it was you. We could blame it on you, but I don't think it was. But now you only have to practice the even ones.
Okay, great.
Or could wait a second, she went to me.
Yeah, so the way I encourage people to look at the model is you pick out 1 or 2 points on the model that you think you're not doing that well right now, and just incorporate this and see where it takes you. So again, the first point, which I think is a great one, is, have you ever seen a patient like this before? Maybe probing is not something you do enough of. How did you get to this point? And if you think this extends the discussion, it doesn't. It really doesn't. Once you become proficient at this, it's 1, 2, 3. This does not extend your day. It does not extend your time with a trainee, but it makes it all inclusive. Other questions? Again, thanks so much for the invite and for being here so early in the morning.
I think Dr. Kirk, you're good?
Okay, I'm okay.
Excellent. Thank you all so much.